Thank you all for coming. Today I'm going to be talking about Apixaban and the prevention of stroke in atrial fibrillation. By the end of this presentation, you should be able to define the risk of stroke in atrial fibrillation, explain the limitation of vitamin C antagonists in the setting of atrial fibrillation, review the pharmacology of Apixaban, review and discuss the Aristotle study, and discuss the pros and cons of the study, and summarize the utilization of Apixaban in the prevention of stroke according to the current guidelines. A comprehensive talk about atrial fibrillation is beyond the scope of this presentation. So let's start by talking about the epidemiology of atrial fibrillation. Atrial fibrillation is the most common arrhythmia requiring hospitalization in the US. In Canada, about 350,000 Canadians have been diagnosed with atrial fibrillation. About one out of every 1,000 people under the age of 50 has atrial fibrillation, and it jumps to 1 out of 8 above the age of 80. The lifetime risk of atrial fibrillation at the age of 40 is 26% for men and 23% for women. Basically, men are more likely to get atrial fibrillation than women, and I would like you to remember this because I'm going to talk about this in a minute. So, what is really atrial fibrillation? So it's atria, and the atria is fibrillating. The atria is quivering. So atrial fibrillation is characterized by rapid, about 400 to 600 beats per minute. The atria is beating at this speed, and the AV node, as you can see on the slide, is blocking some of the signals, and the ventricles is beating at a rate of 120 to 180 beats per minute. And you can see this in the next slide on the ECG abnormalities of atrial fibrillation. On the bottom side, you can see the ECG of a normal heart, where you can see the purple arrow is directed at the P wave, which represents the depolarization of the atria. However, on the top part, the red arrow is pointing at disorganized or absent P wave. The reason I'm talking about the atrial fibrillation, and the reason I'm explaining this is atrial fibrillation. In atrial fibrillation, what happens is some of the atria is not beating strong enough. So some of the blood is not transferred from the atria to the ventricles, and it pulls and it goes into stasis, and this what creates the chance for blood clots, and the blood clots can move to the brain and cause a stroke. So next slide. So of course the goal of therapy of atrial fibrillation is the restoration of sinus rhythm and prevention of complication and improving survival, but prevention of stroke is one of the most important goals of therapy in atrial fibrillation. Stroke is a term used to describe a sudden onset of focal neurologic deficit in the brain, and it is considered the most significant morbidity in patients with atrial fibrillation. Approximately 15% of strokes happen in those with atrial fibrillation. The annual risk of stroke in atrial fibrillation is actually age-related. You can see at the age 50 to 59, the risk is only 1.5%, and it jumps to 23% for people aged 80 to 89. Stroke is the fourth leading cause of death in the United States, according to the Center of Disease and Control Prevention. And stroke was the leading cause, the third leading cause of death in Canada in 2011, claiming the lives of 17,000 people in 2011, which far exceeds those died due to accidents. even stroke survivors are left with some sort of disability. This table was extracted from the Canadian Agency for Drugs and Technologies in Health. It basically illustrates the three guidelines, major guidelines, the Canadian guidelines, Canadian Cardiovascular Society, and the American College of Chest Physicians, and the European Society of Cardiology. As you can see, the three agree on the details, but agree on the major guidelines, but maybe differ in wordings. But they all agree that we have to stratify patient according to the risk of stroke. And also, if you look at the bottom two, according to the CHAD score, they all recommend to using the oral anticoagulant, the novel new oral anticoagulants over warfarin. However, if you look at the American guidelines, it only recommend the Begetran. I think this is only because of timing issue. It is a 9th guideline, and it came out before the approval of the newer drugs. So the first step is to determine your patient risk of stroke using a predictive index. So the question, why particularly CHAD score? CHAD score is a clinical prediction rule for estimating the risk of stroke in patients with non-rheumatic atrial fibrillation. There may be more than other 12 risk stratification schema other than CHAD score. However, the Canadian Cardiovascular Society recommends using CHAD score basically because in view of simplicity, extensive validation, and wide use. Word of caveat, I would like you to look at the CHAD score. So every factor takes 1 point: congestive heart failure, hypertension, age over or equal to 75 years, diabetes, and stroke or cerebral embolism. So the word of caveat is, if you look at hypertension, it is not only high blood pressure, even controlled blood pressure is considered, controlled and treated blood hypertension is considered an independent risk for stroke. And to make it simple, if someone comes to the hospital with a stroke, he jumps directly to 2 factors, which puts him at a level where he should get an oral anticoagulant. What happened if next slide? I would like you to look closely at, this is a predictive index for stroke. I would like you to look closely at CHAD score of 0. It still carries a risk of 1.9% chance of stroke. And that's why the Canadian Cardiovascular Society calls for further risk stratification according to age. Next slide. According to age, gender, and vascular disease. Women may have an increased risk of stroke compared to men, especially after the age of 75. The increased risk of stroke is not fully understood, but may be due to genetic factors, hormonal factors, psychosocial factors. And you remember, this is why when I told you about atrial fibrillation, so basically men are more likely to get atrial fibrillations than women, while women are more likely to get stroke than men. The second step is to determine the patient risk of bleeding. This is called has bled, and the efficacy of antithrombotic therapy to prevent ischemic stroke must be balanced against the risk of bleeding, particularly the intracranial hemorrhage, which might be fatal. Has bled has been validated in a cohort of European study with a cohort of European patients with AFib, and both the European guidelines and the Canadian guidelines recommend using this schema for predicting bleeding risk. As you can see, many factors overlap between Schett score and has bled. Stroke itself can be a risk for bleeding. So this has bled is used to determine the risk of bleeding of the patient, but word of caveat here. It is not to be used to exclude patients from treatment with anticoagulant. And the reason of this, according to the guidelines, the stroke risk usually exceeds those of major bleeding. And furthermore, the stroke would leave the patient with residual deficit and disability, while bleeding might not leave the patient with such disability and might not less likely to be fatal. So has bled should be necessarily shouldn't be used to exclude patients, but should it calls for warrant more monitoring of the patient if you decide to give patient at high risk of bleeding and anticoagulant. Next slide. So looking at warfarin, warfarin is a vitamin K antagonist, which thus inhibits the factors 2, 7, 9, and 10 in protein C and S. It reduces the risk of stroke by 62%, which is quite impressive. However, the limitation of warfarin is many. The risk of thrombosis or bleeding when target INR is not achieved. INR outside the therapeutic range is 1/3 of the time, and there is a lot of variability in dose response due to genetic variation and genomic variation in the vitamin K epoxide reductase inhibitor, and there is a lot of drug interaction with prescription drugs and non-prescription drugs. Next slide. I would like you to look closely at this slide. It's not going to be because of drug interaction or dose variability. It's going to be because of this. This graph, I'm sorry it's not really clear, but this graph depicts a linear regression showing the time in therapeutic range versus adverse events. And they found a negative relationship between time in therapeutic range and the adverse clinical outcome. Efficacy of warfarin is achieved if patients are appropriately anticoagulated 60% of the time. So if the patients are not having the INR within range at least 60% of the time, this is when the patient gets, this is when puts the patient at risk of either a major hemorrhage or stroke. And it has been found that only 1/3 of population is receiving a warfarin where they should have, and whoever is receiving warfarin in community is not actually getting the full benefit of warfarin. So let's take a moment and think of an ideal antithrombotic drug. I think it should be oral. It's going to be a lifetime commitment, preferably once daily. It should be effective in preventing stroke. It should have predictable pharmacokinetics. Monitoring should be limited. Risk of bleeding is low or at least minimal, and shouldn't have a lot of drug interaction and minimal food restriction. So Apixaban. Let's switch gears now and speak about Apixaban. The graph shows that clotting cascade. Oh, sorry, it's not appearing, but the Apixaban binds selectively with factor XA. And inhibition of the glycylation factor XA prevents the conversion of prothrombin to thrombin, which is a crucial step in the clotting cascade. Unlike other anticoagulants, it doesn't require other cofactors. It binds selectively with factor XA. Let's speak about pharmacokinetics of Apixaban. For the absorption, the absolute bioavailability is approximately 50%. The Cmax it reaches Cmax within 3 to 4 hours. Food does not affect the bioavailability of Apixaban. It is still metabolized by the CYP, cytochrome CYP system, and it is not a prodrug drug, and there is no active circulating metabolites. It is eliminated by multiple pathways, and it's only around 27% renally cleared. The half-life starts at 6 hours, and then when the patient takes a couple of doses, it goes to 12 hours. This shows a drug interaction for Apixaban. For the far left is strong CYP, CA4, and B-glycoprotein inhibitors. B-glycoprotein is an efflux system, so this is the left side. On the right side, the strong inducers, and in the middle, just moderate. And when you have a moderate inhibitor, then really there is no dose adjustment necessary. For the inhibitors, ketoconazole with co-administration of ketoconazole and Apixaban was found to increase the exposure of Apixaban and the area under the curve and Cmax by about 2 folds, from 1/2 to 2 folds, and this increased the risk of bleeding of the patient. And in this case, the product Apixaban monograph asks for reduction of the dose to 2.5 twice daily. Next slide. Apixaban dosage. Apixaban should be taken 5 mg twice daily. 95% of patients in the Aristotle trial received the dose of 5 mg twice daily. Only 4.7% didn't receive the full dose. They received 2.5 mg twice daily. And the product monograph asked for the reduction if you hit 2 or more of this criteria. If the patient is 80 or more, or if the patient weight is less or equal to 60 kilograms, or the serum creatinine is 133 micromole per liter. If any of these two, then you may need to reduce the dose to 2.5 milligram. And we'll see this when we discuss the trial. So, quick history about Apixaban. It's a joint venture by Pfizer and Bristol Myers Squibb. It has been approved in Europe for a long time, and it is approved in Canada even after the cardiovascular, the Canadian Cardiovascular Society, and they left a note in the guideline to say recommending Apixaban when it gets approved. So about the Aristotle study trial, Apixaban for reduction in stroke and other thromboembolic events in atrial fibrillation. The primary objective of the study was to determine if Apixaban is non-inferior to warfarin at reducing the risk of stroke and ischemic or hemorrhagic, and in patients with atrial fibrillation with one additional risk factor. The trial design was double-blind, double-dummy design, randomized clinical trial. The primary objective, as I said, non-inferiority of Apixaban to warfarin, and they say if they meet the criteria of being non-inferior to Apixaban, they would go and test for superiority of Apixaban. And they provided intention to treat analysis by the end of the trial. So let's look at the inclusion criteria. Again, the patient to be enrolled has to have atrial fibrillation and at least one additional risk factor. And if you look at the risk factors, it reasonably mimics or coincide with the SHAD score, age over 75, and so on. The exclusion criteria, next slide. So this is not an inclusive list, but I would like you to look at just a few criteria. If the patient has severe mitral stenosis or prosthetic mechanical heart valve, they were excluded from the trial. If patient had a serum creatinine of 221 micromole micromole per liter were excluded from the trial, basically creatinine clearance less than 25 ml per minute. And also if the patient has liver impairment. And that's why they don't have dose recommendation in those three patient population. So randomization and the study drugs. So the intervention was like this. It was two groups, double dummy. Each group received either Apixaban and warfarin placebo, and the other group would receive Apixaban, placebo, and warfarin. And as I said, 95% received 5 milligram twice daily, and the rest received 2.5 milligram twice daily, according to the criteria that I mentioned before. Study outcomes. So, so the study outcomes were efficacy and safety outcomes. The primary efficacy outcome was stroke or systemic embolism, and secondary efficacy outcome was death from any cause. The primary safety outcome was major bleeding. And so the definition of stroke and major bleeding was very, they had very definitive definitions for those two. And for the major bleeding, they defined the major bleeding according to the International Society of Thrombosis and Homeostasis. And basically, the bleeding was as a bleeding accompanied by hemoglobin level of at least, decrease in hemoglobin level of at least 2 grams per deciliter, or transfusion at least 2 units of red blood cells occurring at a critical site, or led to death. So the follow-up for the trial was about like 1.8 years, about 2 years. They followed 18,000 patients with non-valvular atrial fibrillation at risk of stroke, about 1,000 centers in 40 countries, 9,000 patients were assigned to Apixaban group, and 9,120 patients, and 9,081 patients received warfarin. The two groups were well balanced with respect to baseline characteristics. Again, the slide is not very clear, but this is the primary efficacy outcome. And this is following the patient over. The time would be on the x-axis, and on y-axis would be the event, which is stroke or systemic embolism. About 212 patients in the Apixaban group developed stroke, compared to 265 patients in warfarin group developed stroke, which is like 1.27% to 27% in the Apixaban group, compared to 1.60% in warfarin group. And this is called the Kaplan-Meier. It's just an estimate of the. It is fairly used in survival analysis studies. And this is the primary safety outcome, which is major bleeding. Major bleeding. Major bleeding occurred in 327 patients in Apixaban group, compared to 462 patients in warfarin group. And the intracranial hemorrhage occurred in 52 patients in Apixaban, compared to 122 patients in warfarin group. So in conclusion, in patients with atrial fibrillation, Apixaban was superior to warfarin in preventing stroke or systemic embolism, caused less bleeding, resulted in lower mortality. But it doesn't, a certain trial doesn't come without limitation. Around around 30% of the patients were on aspirin as well, and they provided an intention to treat without per protocol, which means that usually they use per protocol analysis when they are trying to submit for non-inferiority. I don't know how significant this limitation is, because apparently the trial is adopted by the 3 major guidelines, so I don't think it was really an issue. So let's put Apixaban to the jury. Would it to see if this new kid stands out? So I left this okay. So I left the slide empty because this could be controversial and is subject to clinician's judgment. But let's review what we know so far. So it's an oral drug, which is the good thing, because it's going to be could be a lifetime commitment. So it is not once daily, and in one systematic review of the association between dose regimen and medication compliance, once daily can reach compliance of 79%, while if you decrease, this is in general, this is not Apixaban specific, if you decrease the administration to twice daily, the compliance decrease. It was effective in preventing stroke. It has fairly predictable pharmacokinetics, and the BID dosing actually provided predictable pharmacokinetics with less peak to trough ratio difference, and risk of bleeding was low or minimal, and it still has the word of caveat about the risk of bleeding is low or minimal. Yes, it causes less bleeding than warfarin. However, when tested in another study added to antiplatelets, it actually caused more bleeding. So yes, it causes less bleeding than warfarin, but it doesn't mean that it doesn't have a risk of bleeding at all. Also, it doesn't have a food restriction, it can be given without food. And the last thing, reversibility of anticoagulation. This is beyond the scope of this presentation, but it doesn't have an antidote like warfarin. So next slide. And this is what I come, but it's subject to your personal opinion. I give Apixaban 6 stars out of 9. Next. So so what is left to be answered is the question to be answered: is it safe to use Apixaban or Rivaroxaban in a patient with prosthetic heart valve? The American guideline recommend against using dabigatran in patient with mechanical heart valve, and this was based on a realigned trial where and this trial was actually stopped early because they found that 252 patients that was enrolled in, they had an excess of strong embolic and bleeding events. And so that's why Apixaban wasn't tested in patients with mechanical heart valve. So is it going to be tested? This is a question to be answered. Renal disease, is it really safe in patients for creatinine clearance under 25 ml per minute? Is it fair to ask this question considering that it's only 27% renally eliminated? And could it be used in liver failure or liver impairment? And when I looked at, personally, I couldn't find any trial comparing the new anticoagulants head-to-head. You only have systematic reviewing different trials and trying to find which is better. But we didn't see a head-to-head trial comparing the novel oral anticoagulants.
Last thing that I thought would ever happen at the age of 19 was to have a stroke.
As the parent of 2 healthy young adults who were just being successful in the world, you never ever think that critical illness is going to strike one of your children.
Experiencing a stroke can be life-altering. For Janelle, her goal to complete a university education seemed suddenly impossible to attain.
I couldn't speak correctly or fast as I used to. I couldn't do math. I couldn't walk.
When we got home, we continued to pursue all of the avenues of rehabilitation that were available in our community. And at the same time, we returned to Foothills also to continue some outpatient rehabilitation.
Roxanne became Janelle's full-time caregiver. Often, family and friends take on that role for loved ones who have experienced a stroke.
After my stroke, my mom was my rock. She was my advocate. She was my communicator when I couldn't. I knew that I didn't have to worry about what was going on outside of my little bubble because I knew my mom would take care of it, so I could focus on simply recovery.
I can't imagine anyone going through a journey such as stroke alone.
Roxanne quickly found out how important it was to find a reliable source of information to ensure a quick and safe recovery for Janelle.
It was only after she was stabilized that we were so grateful to understand through the education, the research and development that the Heart and Stroke Foundation had provided to us, that we knew that there was hope on the horizon. And for that, our life has been immeasurably improved, and we will always be so thankful.
Stroke recovery is a long, long journey that I don't think you ever really finish, because you can always improve something. And I would just like to say thank you to all of the supporters of the Heart and Stroke Foundation.
Today, my daughter Janelle is a doctor and a happily married young woman. We have taken on a positive life path, and I'm here to tell you that there is life after stroke.
And in closing, atrial fibrillation is the most common arrhythmia requiring hospitalization in the US. Stroke is considered to be the most significant morbidity in patients with atrial fibrillation. Patients with atrial fibrillation should be stratified for stroke using Shell score and risk for bleeding using HAS-BLED. Warfarin is effective in preventing stroke in patients with atrial fibrillation, but it has many limitations. Apixaban is a novel oral anticoagulant that inhibits factor XA, the crucial step in the coagulation cascade. Aristotle's study was developed to determine if Apixaban is non-inferior and or superior to warfarin in the prevention of stroke, with one in atrial fibrillation with one additional risk factor. Aristotle is a well-designed, double-dummy, double-blinded, randomized clinical trial in around 40 countries. Apixaban was found to be superior to warfarin in preventing stroke secondary to atrial fibrillation, and had lower incidence of bleeding and major or intracardiac. Apixaban is considered an option for patients who cannot take warfarin, either for clinical reasons, for those who cannot, or for those who cannot commit to lifetime lab monitoring. Thank you all for coming. Now I'm open to questions.
If you had a patient who bled on Apixaban, what would be, and they were a high-risk patient, what would be your suggested alternative? Would you go to warfarin or one of the newer alternatives?
Comparing Apixaban to the newer, Apixaban actually was the only one to show that it had less bleeding than warfarin and less bleeding in the trials than dabigatran and rivaroxaban. I wouldn't go for any other of rivaroxaban and or dabigatran. If at all, I would go back to warfarin. But again, I'm saying that there is no head-to-head trial for the new anticoagulants. But to go to the other new, I wouldn't suggest yet. But this is my my opinion based on what I read.
No, I had that question from one of the physicians, and I gave my answer. I was just curious what yours was.
Thank you. So my question was, if it was a non-inferiority trial, how did we get from that to superior? I'm a little bit lost on that. I don't remember.
They tested in the previous trials that warfarin would reduce the risk of stroke by 62%. They say that if they could reach 50% of that, then they would be non-inferior. They were over that. That's why they moved from non-inferior to superior. That's how I understood it.
So mid-trial they switched it up? You mean the parameters?
Not the parameters. They tested first for the non-inferiority, and it was in non-inferior. Then it showed that after that it is superior.
They re-crunched the data again.
More questions?
Okay.
Go ahead.
I was at a stats talk, and they talked about when you take these non-inferiority trials, the problem with them is that you can't then flip them because the parameters are wrong. I don't fully understand that, but it was very critical of, not your talk anyway, the process of our drug companies are taking a non-inferiority trial. You cannot extrapolate that data, and when they try to, it's apparently flawed.
That's why I said, when I said about the limitation, it is a limitation. They use the intention to treat, and if you compare the intention to treat to per-protocol intention to treat, if one patient after the randomization is included, even if they fall out of the trial, they included in the analysis by the end of the trial. So I don't know if this is really significant about Apixaban. It has been approved, and it has been it's shown that it's superior. So again, it is a limitation of the study, and I can't tell you if it is it's really it's something to question or not.
What is the trade name of Apixaban?
Eliquis.
Sorry?
Eliquis.
Okay.
Yes, you have a question.
I don't actually. I just a little question maybe. Did you come across anything that told you whether you know, in terms of our institution here, whether you know whether it made a difference whether you used the BID dosing or Q12 chronically?
That's a good question, and to be honest, I didn't look. I didn't look closely to see in the trial if it was used every 12 hours or just BID. However, again, after few, the half-life is 12 hours. They actually tested 10 milligram a day. They tested to see if 10 milligram a day would be a better option.
Mm-hmm.
However, the peak to trough ratio was way bigger in the 10 milligram
Mm-hmm.
than in the 5 milligram. 5 milligram would provide a smooth without fluctuation in the blood level. So
Not as critical if they missed a dose either.
yes.
So it probably doesn't matter in the long run.
You know, I will tell you what actually the makers of Apixaban say. They say by BID dosing we just hit the sweet spot. They say now we are at a level where we are not putting the patient at risk of bleeding or a risk of stroke.
But are they BID 0800 1700 or are they BID 08 and 20?
That's what I said to.
Do you know what did they do in the trial?
That's what I said to Cassie. I didn't look into if they are given every 12 hours or just BID. It doesn't matter, but again, the half-life is 12 hours. I'm assuming, maybe wrong, that it was given every 12 hours because the half-life is 12
Well, in
hours.
reality, people are probably taking it at their home they're taking it at home. It probably is, they're not being consistent anyway. They're like 10 hours here, 12 hours there, 14 hours there. You know what I mean? Like it's not exact. They probably don't, oh, my alarm's gone off, I gotta take my Apixaban.
So,
you know.
again, and I say that, and I didn't give Apixaban a star being BID, because BID
Reduces
is not,
adherence, yeah.
and actually, when I looked at many elderly patients, they usually take one dose, even if it is in a blister pack. They usually take, sometimes they take only the morning dose and they forget about that dose.
And just maybe one small comment about your check, now that you've mentioned the check, this reminded me, just a point of discussion. In the reversibility, you know, the literature's always talked about the fact that you can give some vitamin K, reverse the warfarin, you know, to have surgery or whatever indication. But the reality is, I mean, you're talking about, you know, 4 or 5 day half-life with warfarin. you know, when you're talking about a 12-day half-life, 12-hour half-life, you know, if you can delay your procedure by 12 hours, if you have that luxury, you're virtually clearing the drug anyway.
That's right.
So, you know, in terms of emergency reversal, I mean, if the guy's actively bleeding, you know, I mean, you have to judge the emergency of the situation. But whether they were on warfarin or Apixaban, it's not going to matter. They're still bleeding.
And yeah, I looked into trial, but I didn't read a lot about it. But they are looking at that, and having an antidote, would it really make a difference? Is it
turning out to be the big problem we thought it would be when the drugs got, and we're not really seeing it. We've had patients come in with hip fractures and stuff, and they just take them to the OR. And the ones they've done haven't had problems, but they've been few, you know. Case example, not a double-blind, random controlled study.
Thank you all for coming. Thank you so much.
Thank you.